If you watch medical dramas, you probably have a very specific image of how life ends. Alarms blare, doctors sprint across the room, and the monitor drops to a sudden flatline. In a clinical setting, death is rarely an instantaneous event. It is more often a gradual cessation of circulation and breathing, a process where the body's systems shut down in a predictable sequence. Because death is a biological transition occurring over time, the medical system must recognize when a patient has moved past the point of recovery and into the active process of dying. Identifying this transition requires diagnosing imminent death syndrome. Once crossed, the medical team must execute a total reversal of objectives. The hospital system pivots, shifting focus entirely away from life extension and toward the active management of dignity and comfort. This creates a difficult tension for caregivers and families. They must learn to turn off life-saving monitors and observe the physiology of a dying body without the immediate impulse to panic. Managing these final moments requires a conscious effort to override the reflex to intervene, trading the instinct to fight mortality for the focus required to maintain the quality of a patient's remaining time. The biological timeline often begins with extreme prostration, as the patient loses the strength to move or the ability to swallow fluids. As the body fails, it prioritizes blood to vital organs. Circulation retreats to the core, leaving extremities cold. Breathing patterns also shift to Shane Stokes respiration, periods of deep breaths followed by long pauses. These physical markers signal an irreversible systemic shutdown. They are expected physiological checkpoints, not temporary medical emergencies that require a fix. Loved ones may also witness agonal breathing, which manifests as sudden reflexive gasps. While it can look like a struggle, it is a natural brainstem reflex rather than a sign that the patient is suffocating. Similarly, the death rattle occurs when normal secretions pool in the upper airway. As shown in this cross-section, the sound is produced simply because the patient can no longer consciously swallow or clear their throat. These sounds often cause distress for those at the bedside, but they are unconscious biological functions. They do not indicate that the patient is in pain or experiencing respiratory distress. In clinical settings, understanding these signs allows for the formal withdrawal of life-sustaining therapies, or WLST. For pediatric patients who are organ donation candidates, the process is even more precise. After the withdrawal of therapy, doctors observe a strict hands-off period to confirm the permanent cessation of circulation before declaring death. Outside the hospital, the challenges are different. For homeless patients without family or surrogates, securing an advance directive becomes a vital medical intervention, ensuring their wishes are documented before they lose the ability to communicate. In these environments, clinicians must use trauma-informed care, adapting physical exams and pain management to account for substance use histories or a lack of resources. Ultimately, a dignified death requires stripping away standard hospital expectations and adapting the medical response to the specific reality of the patient. When medical interventions are minimized, the focus shifts to the immediate environment. Alarms are silenced and monitors are moved into the background. At this stage, clinical care takes the form of mucosal hydration, the adjustment of lighting, and the careful management of sounds and smells in the room. When the body has reached the end of its curative potential, managing the sensory experience of the room becomes the primary clinical objective. That environment is critical because of a profound biological reality. Hearing is often the last sense to fade. Even when a patient is entirely unresponsive, they may still be absorbing their surroundings. Because of this, physical touch and spoken words remain vital forms of support. Understanding the objective signs of the dying process allows caregivers to stop watching the machines and start focusing on the person. Gently removing the fear of these physiological reflexes allows families to protect a patient's dignity and sustain a connection that lasts until the final breath.